Hello and welcome, everyone. I see that folks are still joining. We had a lot of participants register, so I still see the numbers climbing, but I wanted to log in and let everybody know that we are here. We're going to get started in just a second, but I wanted to give these folks that are still joining time to come in before I get through some of the introduction and the housekeeping things. So let's give it another 35 to 45 seconds or so, because the numbers still keep going up, and I want to give everybody ample time to get their questions answered with some of the housekeeping questions that we have about CEUs, etc. Makes it easier if everybody can hear it at the same time. So we'll start here in just a minute. I appreciate everybody joining me here today. All right, I think it looks like it's calming down. So why don't we go ahead and get started. Hi, everybody, welcome. Today we're going to talk about 3 diagnoses which present somewhat clinically similar, but as a therapist, it's important that we recognize when these characteristics are present in our patient or our resident or our client, if we're treating them from an outpatient perspective, because your assessment tools may change, your goals may change, the referrals you bring in for the patient may change. The interventions may differ, right? And like I said, most importantly are those referrals out, right? Because delirium, depression, not under our scope of practice, but we do want to be alert to recognize when these are present and affecting our patient's life and their performance. So let's go ahead and get started. I am Shannon Leem. I'm the National Clinical Director for Aegis Therapies. Here are my relevant financial and non-financial disclosures. So for our opening housekeeping here, we've got all lines are on mute. If you are sharing your screen with somebody who did not register independently for this particular course, but they still want to receive continuing education credit, please go ahead and share the name and the email of that participant in the questions feature or in the chat feature, whichever you see in your banner, so that we know that they are there and we have a record of that participant being there. And that if they want continuing ed, then we can show them on our reports and make it a more seamless process that way. The brochure and the handout are available in the attachments in your banner. It should be under the handouts section. If you look in your banner, if you're on a laptop in the banner, there's several selections there that are in gray. One of them should say handouts, and there are handouts there. One of which is the PowerPoint that we're going to go through here today. One of which is the ASHA bubble sheet, or the participant form for ASHA. So if you are a speech language pathologist and you want to receive continuing education, pull down that ASHA bubble sheet, and you're going to send that ASHA bubble sheet completed back to Shyla Hamrick. You'll see her email here on the screen, shyla.hamrick@aegistherapies.com, and that's for 1 week. So in 1 week, to send that back so that when we submit all of these to ASHA, we have it as a one submission, one bundle of participant forms. For OTs and CODAs wanting credit, there is a document in the handout section for you specifically that tells you your next steps. AOTA requires a short quiz to release the certificate and the continuing education credit to you. So in the handouts, there is a QR code that's there. You'll also get an email to be able to go to that quiz, to be able to fill it out, and then we'll release your certificate after successful passing of that particular quiz. This presentation is going to take about an hour, probably a little bit less. I did want to leave plenty of time for questions at the end, knowing how many people are going to be on today's call. I'm not saying I have all the answers, but we certainly can talk through any questions that you might have, and we can go through those together. And then after all of our talking today, the certificates will be emailed to you after the course is complete, within about 1 to 2 weeks after today's course is complete. So let's dive in. So our objectives today, hopefully at the conclusion of today's event, you're going to be able to identify the key differences between dementia, depression, and delirium. We're going to determine the questions to ask either the patient or a caregiver or family member to discern the difference, right? We're going to involve the key elements of the patient's care team to help sort through these particular diagnoses. And then we're going to have an ability to tailor an assessment to specifically address the unique elements characterized between dementia, depression, and delirium. Specifically, I'm not saying we are diagnosing or assessing specifically dementia, depression, or delirium. What we are saying is that when we see these particular characteristics, or in some of our assessment tools or screening tools, these characteristics shake to the top, that lend themselves to be a credible, okay screen. Yeah, we think, yeah, this patient has characteristics that are consistent with delirium or depression, and then what to do with that as a next step, right? So it's a way to be able to bring in the proper care team members to be able to support the patient if these characteristics are present. Many times we as therapists, we've seen a patient who the family describes as not acting like themselves, or their forgetfulness seems to be getting worse. And because these three conditions have an overlap in their symptomatology, it's key that therapists understand the clinical symptoms. And by the end of the talk, you should be able to identify those key differences. And then specifically, if you suspect any or all of these three, what those steps should be, what you should do. So let's set the stage with a typical patient. So here's our scenario. You get an evaluation referral for Louise. And this may be in a skilled nursing facility environment. This may be in a home health environment. This could be in an outpatient setting. The patient's coming to you as an outpatient. So her background is she was recently seen in the hospital due to an exacerbation of her COPD and a mild urinary tract infection. She was very unsteady in the hospital, frequently getting up out of the hospital bed despite the nurses there continually instructing her not to get up without using the call bell. Her daughter thought it was a bit unusual for her mother not to follow directions, but she knows her mother does have forgetfulness. She's been meaning to take her mother to her physician due to her gradual worsening of memory and general confusion. And now that she's been discharged from the hospital, the daughter expected her mom just to kind of get back to her normal self because of those things that were addressed in the hospital, those were resolved or resolving. So she anticipated mom would just flip back to her normal state of mind. And as you examine Louise and you talk with the daughter, you notice some areas of concern. Louise seems distracted and not fully participating in the discussion. She's having difficulty following your request and the conversation at hand. She doesn't seem to remember the general event that took place over the last few days in the hospital, becoming a bit upset when reminded she was in the hospital for a few days. And you as a therapist need to get to the heart of the matter. How does her current state of mind and history of forgetfulness impact your assessment and her potential treatment needs? Are these recent changes in mentation and behavior expected to resolve to her prior levels, or is this her new normal? So let's begin by starting with the first of our three diagnoses that we're going to talk about today. Dementia is an umbrella term used to describe several progressive neurological disorders that surround progressive memory loss, challenges with problem solving, personality changes, and changes with communication. As you can see, we've listed some of the primary diagnoses that are consistent under the dementia umbrella. We have Alzheimer's disease, Pick's disease, Lewy body dementia, Creutzfeldt-Jakob, and vascular dementias, which are very prevalent. And as an aside, there's a website called dementia.org, which goes into all the different diagnoses that tend to have a bend towards having a dementia component. So I encourage you all to go and take a look at that website. It's really informative. So dementias have a slow onset and a slow progression. It doesn't happen suddenly. Memory loss doesn't occur suddenly. And to be very clear, and this helps also when talking to family members, or maybe even nursing sometimes, it's not considered a normal part of aging. So when we talk about the issues with forgetfulness, problem solving, some of the behavior issues that change, sometimes that's attributed to, well, grandma's 85. What do you expect? I do not expect grandma at 85 to be oriented. I don't expect her to know who the president is. And we know that as the standard for normal aging, and a standard issue 85-year-old will actually be fully oriented. They will know who the president is, and it's not a normal part of aging for that to be altered or that to not be the expectation. So it's good of us, even as clinicians, because I think sometimes we lose sight of what is the standard. We are surrounded many, many times by folks who have these disorders, have communication issues, have mobility issues, balance issues, difficulty with range of motion and strength problems. And we see it over and over again. And sometimes we lose sight of that is not normal, right? The standard is slight muscle loss, word finding impairments, right? That's normal aging where they can't quite find the right word. Slower ability to respond, but the response itself is still accurate, right? Vocabulary tends to stay the same as you age, and the variability of all the words that people use tend to stay the same. And when we see that change, when that is not the case, we need to remember that that's not a normal part of aging and to investigate further. So next, we're going to talk about delirium, right? Here's our second diagnosis. Delirium can be defined as a neuropsychiatric disorder that manifests itself in reduced awareness in the environment and confusion. It typically has a quick onset and may be tied to a recent escalation of medical events such as medication changes, infection, surgery, or changes in metabolic balances such as low sodium. And I think we've all recognized a patient who has some of these hallmarks. I think we all, when we work with the elderly, we recognize very quickly that a UTI, right, an infection, can really throw off a very robust elderly or senior individual. When that comes about, changes in memory can happen, confusion can happen. We're going to go into some of the other symptomatology with delirium and all of that. And I think we have begun to recognize those signs in the population that we see, but it may not be as obvious for family members or other folks in that patient's care team, care circle, that they may not recognize that that's what that might be, and to lead in the direction of investigating that further. So with delirium, there are three types of delirium that can present itself. There's hyperactive delirium, hypoactive, and a mixed delirium. So under hyperactive, it's an irritability, it has combativeness as a hallmark, uncooperative, easily distracted. The patient can wander or climb in and out of bed, and this can be very atypical for the patient. In a hypoactive form of delirium, the patient can be sleepy or withdrawn, they can have visual hallucinations, and generally have little interest in interacting at all. And then there can be a mixed diagnosis of delirium, mixed hyper and hypoactive, which can be a shift between the two at any particular time. It's important as an outside observer to determine the patient's baseline of cognitive functioning to help discern if we see these changes in mentation suddenly as a result of an acute change in the patient's normal level of cognitive functioning. So it's really good to know. So when we're in a skilled nursing facility, and I suspect that many of you here today work in the skilled nursing facility, that some of our long-term care residents, we may typically recognize, hey, something's not right with this particular resident. I'm sensing something is different. It doesn't typically act like this. So we might see those things coming on. But if the patient is in a home health environment or as an outpatient, you might see them and they come in and they're really not acting the same. You want to make sure that we involve family members to be able to ask the questions, right? What do we see happening? Why is this happening? So let's get into the last diagnosis we're going to talk about, which is depression. And the American Psychiatric Association describes a depression or a major depressive disorder as a serious medical illness that negatively affects how you feel, the way you think, and how you act. And depression can be described as a discouraged mood that can accompany a calamitous life event, such as the death of a loved one, financial stress, natural disaster, or a serious illness. And some of the symptoms that accompany a depressive disorder are poor concentration. A sleep disturbance can come, whether that's too much sleep, not enough sleep, a change in appetite, and that can be weight loss or weight gain, eating too much, eating too little to maintain a nutritional function. And then the loss of interest in activities that were previously enjoyed. The severity of the impression can range from mild to severe in nature. So I put together on this slide and the next slide a grid where we talk about a common key feature such as onset, duration, cause, course, We're going to go into the effects at night. We're going to look at attention span, consciousness, etc., and look at the comparisons between the three different diagnoses. So for an onset, we've already discussed for delirium, it tends to be a sudden onset, right? We've got a medication change. We've got an infection that comes about after a surgery, anesthesia coming in. We've got a delirium. It's sudden. It's a swift change. Dementia, slow, gradual onset. And for depression, it can develop over weeks or months. How long it lasts, so delirium can last days to weeks, could be longer, depending on the manifestation of the infection or whatever the causality is for it. Dementia is usually permanent, right? There's no cure for dementia, so it tends to have a progressive and continual movement down the progression of the disease. And then for depression, it depends on the treatment. If left untreated, it can be long-lasting, but if it tends to have treatment associated with it, whether it's behavioral or medical, there can be some reversal of that. From a cause perspective for delirium, another condition tends to cause the delirium and manifests itself as a result of something else. Dementia has its result of a chronic brain disorder. And for depression, its cause is from a life event, a medical illness, change in life responsibilities, loneliness, isolation, or medication side effects can also bring it about. The course of it for delirium, usually reversible. It stops and reverses itself. For dementia, it's slowly progressive, doesn't reverse itself typically. And for depression, it's chronic or depends on the treatment, how long it tends to last. So at night, delirium is almost always worse. And that might be the first place you hear about it from a family member or from nursing, that something is happening with the patient in the evening. Same thing with dementia, often worse at night. We know about sundowning when their sensory overload throughout the day has kind of come to a culmination point as the sun begins to set, and they're having difficulty with all of the integration of what's going on, the change in the lighting, the move from day to evening, the shift into an evening routine sometimes can be very difficult. And for depression, they tend to have difficulty sleeping, where trouble falling asleep, problem staying asleep. That usually is the feature for sleeping with depression. Attention span, delirium, greatly impaired, difficulty maintaining attention on a task or a conversation. For dementia, it's unimpaired until it becomes in the moderate severe ranges. That's when you see the attention span start to shrink for regular activities or even conversation. And depression also can't maintain attention onto something for a long period of time. Intrusive thoughts can be part of it, ruminating, all of those can have an element in there. For the level of consciousness, for delirium, it's variably impaired. Sometimes they're alert, sometimes they can be somnolent, and depending on what type of hyper or hypoactive delirium they have, it can also be more severe in that, right? More alert, more active, hyperactive versus less alert and somnolent and very tired and lethargic. For dementia, the level of consciousness also tends to be unimpaired until the more severe stages, more profound stages. In depression, the level of consciousness is usually not impaired, that their ability to be alert in their environment is normal. Orientation to time and place for delirium tends to vary. For dementia, we know it can be impaired. And for depression, the patient or the resident is typically oriented. They know what day it is. They know what's going on around them. They know who they are. They know the day's events and what's been happening. They have little interest in them, but they know what's happening with it. Use of language for delirium, slow, often incoherent. Words and content don't make sense. Conversational exchanges tend to be not connected. If you carry on a conversation, it feels like you're having one conversation and they're having a completely other one, and they don't connect. Dementia, difficulty finding the right word at certain times. And then we know in the very profound stages, language, poverty of language and thought is very profound. And same with, on the depression side, language is usually not affected. Vocabulary, their grammar, and syntax is all usually intact. And from a memory standpoint, delirium, memory can be varied, dementia typically impaired, And for depression also, it can be varied. So here we've reached our first polling question. And Shyla is going to open up our poll. And we have, which diagnosis has a sudden onset? And when you get your options, I want you to select A, delirium, B, dementia, or C, depression. I didn't get a pop-up to show my poll. There we go. I've got it now. People are responding. Looks like we've got 70%. If you see it popping up, go ahead and hit your vote. All right, we're going to go ahead and close voting. We're at 75%. 97% of you have said delirium, and that is correct. Delirium is a sudden onset, a sudden shift, a sudden change. So now we're going to move on to polling question number 2. Typically, how long does delirium last? A, it's usually permanent. B, it depends on the treatment. And C, it could be days to weeks or could be longer. And there you should have your polling question up. We're about 50% of folks who voted. We'll let it keep going. All right, we're over 75% voting. And 72% of you said that it was days to weeks or could be longer, and that's the correct answer. Depends. The rest of you said it could depend on the treatment, and I could see where you'd see that, right? If left unchecked, especially with infections, et cetera, it could seriously impact the patient. So I could see where you'd move towards that, but the true answer is days to weeks, could be longer. All right, I wanted to put in here a section where we're involving the daughter in this specific scenario. We're talking about Louise. So let's say she's been a new admission into the skilled nursing facility, or she's in home health and you've gone to see her as a new patient in home health, but the daughter is very active. So some of these you could shift to a question of a known caregiver. If you're in the skilled nursing facility, it could be home health or a CNA that you know knows this patient really well, the activities person if they know this patient, could be the daughter or a family member who we know is in the patient's orbit pretty regularly, or the nurse to answer some of these questions. But I did want to have a series of questions you'd want to have answers to when you walk in to see a patient like Louise, where you don't know what might be causing some of the symptoms that you're seeing here. So the first question that's good to ask is, what was your mother's cognition like before she had her medical change? I think we all know that's a good question. What was mom like? What did she do? What was her day like typically? What would she do during the day? How would she engage? What did she do during her free time? And get to know Louise before this medical event. What would she do and how is that different than what we're seeing today? Was she able to follow a simple conversation like the one we're having now? And I'm saying that as if the daughter is there present with us at the time of the evaluation. If you're in the home, that typically might be what's happening. If you're in the skilled nursing facility for a new admit, sometimes the family is there for those evaluations. So pull them in, really lean heavy into somebody who knew Louise before you did, right? Because they're usually a good marker for what we want to know. So was she able to follow this conversation like we're having here now, or would it be difficult for her? Would you generally say her cognition and behavior now is worse, the same, or better than when she was in the hospital? And I say better because sometimes medications, if Louise struggled at home and the daughter was struggling with her remaining in the home, wandering, getting into things in the house that she shouldn't have, then she got sick, went to the hospital, and she may be on medications that are kind of dampening that ability for her to get up and get going. The daughter might think that she's better, her behaviors are better than we were before. Still important to know, but we want to know why the daughter thinks they are better, and get into what changes that she might see. Is her activity level now that she's out of the hospital, or if we're seeing her at home, now that she's here at home, is it the same as it was before, or are you seeing a change? And is that related to, when I say activity level, is that related to mobility issues, right? We're going to talk about from a physical standpoint? Is her mobility different than it was before? So that might be why her activity level is different, and so get into that. Is she having trouble sleeping or having more difficulty at night? That may be a question for the CNAs, or you might look in your EMR to determine, is she struggling in the evening, or if she's a home health patient, then certainly the daughter might actually be the first thing that she's telling you, because daughter is tired. My daughter might have some really good questions as to how to solve for that. All right, so during our assessment, we're going to look at several ways to help differentiate among the conditions. So the first is a thorough chart review. So I've talked about the chart a couple times. So if the patient had a hospitalization prior to the home care episode or the admission here into the SNF, looking through any available documentation there might help provide some cues and clues to help discern what the situation may be. Were there any medications added to the patient's regimen that may be contributing to this current set of symptoms? Likely, yes. There's probably, if she had an acute care stay due to an exacerbation of her COPD, she had the UTI, likely she's on some antibiotics. They might be discontinuing, or she might be titrating off of them. But likely there are some new meds in this scenario. So we want to make sure that we are looking at the medication list. I know that's a best practice. On the home health side, it's a standard, right? Any clinician who enters the home does a medication review. If you're a start of care clinician, you're going through all the meds and learning what's new, are they all here correct, et cetera. But on the SNF side, it's a best practice for you to review the medications and have a handle on. It doesn't mean that you know all of the meds, all the reasons she's on the meds, all the side effects. But you do want to have a general understanding of what are the medications the patient is taking and what effect they may have on your treatment plan, and what effect they're having on the symptoms you're seeing or the characteristics you're seeing in the patient currently. So that's the first step. We want to take a look at the medications. And like I said, this is not to say that you're the decider about what meds should be taken or changed, but what you can do is analyze the medication as a catalyst for the issues that you're seeing now with the patient. You want to see how her language is when she responds to you. Is it cogent? Is it connected to the topic? Is it flowing properly through the conversation? Is it demonstrating difficulty staying on topic and giving concise answers, or is she going off and coming out? Is she demonstrating good pragmatics, right? If you and I were to have a conversation and I'm not following you, me with good pragmatics, I'm saying I got good pragmatics. If I've got good pragmatics, I might say, I didn't understand that question just then. Can you say that again? Or can you repeat that? Or my mind just went off for a second. I missed that whole series of the conversation. Could you repeat that? Or bring me up to speed again. I'm not feeling like myself, right? That shows introspection. That shows that I have an ability to navigate this conversation with you. If a patient doesn't, or if Louise is not demonstrating that ability, she might get upset. She might wonder what you're talking about and why we're talking about this, or why you didn't address the question she had in her head. And she might wonder what's with all the questions. I think me being a speech therapist, and if I've got speech therapists out there, I should have had a poll that says, how many times have you heard a patient get upset with all the questions that you're asking them, right? What's with all the questions? What's with the 50 questions? I don't need to answer all these, right? So getting defensive at the questions can be a little bit of an insight. Not to say that it's an anomaly, right? They have a right to be angry with having all of this happen to them and not want to go through a game of 100 questions. But being very guarded with, you're asking questions, I'm unsure of the answers, so I'm going to get mad instead of say, wow, that's weird, I don't know what's been happening, right? Again, shows that introspection, that self-awareness, a little bit of condition management, health literacy to some extent, right? Okay, we want to know, is she oriented? Date, time, place, situation. I usually ask the question as I'm sitting there with the chart, looking through the record. I may say, what brought you here today? It looks like you've been through the ringer. That's usually some of the ways you broach the subject. Looks like I've been through the ringer. What happened? What were the series of events, the series of important events that led you to be here with me today, sitting in front of me? What happened? Or say, give me the Reader's Digest version, right? That's a hearken to the senior population. What's the Reader's Digest version of what happened? And can they give some bullet points as to what happened Or do they brush it off? Nothing happened. I don't know why you're here. I'm perfectly fine. I don't need a speech therapist. You OT, I don't need a job. Why are you here? Right? So I think we hear those things, and it's important to kind of dig a little bit deeper. Learn, is it because they don't know the answer, or are they having that verbal banter with you because they're trying to protect themselves from not giving you the right answer? But again, that language is also an important marker for you, as we mentioned the language before. Medication changes, we want to know what's the change in condition. Is there a history of infection that might be brought up? You want to look through the physician notes. Is the physician mentioning any changes of mentation? Do they talk about attention, memory, or motivation issues, or follow through on anything that's happening? Usually in the hospital, there's not much imparted to the patient that they must take ownership of in the hospital, right? Usually everything's being done for them. But you're going to learn about that on the therapy side of things, how their motivation is, how's their follow through, do they take ownership of some of the ability to do things when you're not around. All right, so what further considerations are going to come into play with Louise and her daughter now that you've looked into the record even further? So I'm now maybe going to ask some more questions. So what are Louise and her daughter's goals now that she's out of the hospital in the facility? We're learning what's our discharge transition plan. You want to know that on day one. What's the expectation here? What does Louise need to be able to do to get back to the environment she was in prior to being in your facility? Or if she's at home now, what needs to happen so that Louise can stay in the home and be safe? What impact does the current cognitive impairment have on those treatment interventions, right? So knowing what I know about her cognition now, how does that change the goals, right? And in a minute, we're going to get into assessment tools. So it's important to know if Louise has dementia, especially from the PT and the OT side, if we're introducing adaptive equipment, if we're introducing mobility devices, it's important to know what Louise's ability is to learn something new, if that's a new device, what her ability is to be able to learn that new and maintain it independently, or is she always going to need supervision with it because of her cognitive ability. But if we're erring on the side of delirium, and we think some of this will clear up because of the characteristics she has, because of the chart review that you've seen, then that might not be an issue for the discharge. But it's one that you're going to need to want to ask and look to an answer very early on in the care, so you're not grinding away at goals that are not going to be fulfilled, especially with a discharge transition. That might delay a proper transition. We want to know ahead of time what are the forks in the road and be able to anticipate those early enough so that it has an effective change in the treatment plan. I mentioned up here the PHQ-2 through 9, which is on the MDS and on the OASIS, which is the Patient Health Questionnaire. It's a screening for depression. So in the skilled nursing facility, look to the MDS. What were the results of the PHQ-2? And if you're in home health and you didn't do the Started Care OASIS, look to that go open that in the record and see what are the results of that, to know whether the the depression screening, which is what the PHQ-2 is, what was the indicator on that? So if we're seeing some of the elements, those characteristics, we want to start crossing off things in our checklist. And if the depression screening was not indicative, then we can file that away. We know that, and we can even note that in our record. And what impact might that have on any motivation to participate? So depending on the results of that, you'll know whether there's motivational issues or things that you might need to address. I've talked about the integration of the assistive device already, and then we've got frequency, intensity, and duration impact as a result of the cognitive issues. How will cognitive impairments, if we're leaning in the direction of dementia being the culprit, how will that affect the frequency, the intensity, and the duration of a patient's care? Learning what the patient's attention span is, learning what the patient will be able to tolerate from a communication interaction standpoint, a sensory integration standpoint, is important to know before we set our frequency, intensity, and duration. I'm putting aside the concept that we have to have the care team discussion, right? So PT, OT, ST, all of us need to have a conversation about goal development if Louise is getting all three disciplines, goal development, care prioritization. Everybody's talking about the discharge plan, and we're all planting our flag in those different things that we need to address with Louise. And on the home health side, now we're also looping in nursing. I'm not saying we don't do that on the SNF side, but because nursing is more remote, we need to make sure we pull those nursing member of the team in so that we can have a conversation about their goals and what they're going to address. If anything, they may not be submitting any frequencies for this particular patient. So when we have a cognitive impairment for frequency, intensity, and duration, are shorter, more frequent interventions needed for Louise, or longer, over a longer period of time, what we're going to need to address safety issues, to help with carryover, et cetera. So these are things we'll need to address early on. All right, so now I think we've gotten to our third polling question. So can medication changes be a cause for a change in cognition? Yes or no? I'm pretty sure this is going to be 100%. I'd like to think it's going to be 100%. There's about 70% voted. Okay, we're almost at 100%. 99% of you said yes. Medication can be a reason for a change in cognition. And it's important for us as clinicians to recognize when new meds are introduced to a patient and we notice changes in mentation, changes in cognition. It's incumbent upon us to at least be the one that says, hey, I put 2 and 2 together. Could this new med be causing this change that we're seeing? And not that we're the decider on whether or not that medication should be given or changed or modified or doses changed, et cetera. No, but it is one within our scope to say, hey, I've created this connection, and it does say when I looked up the med that this could be a side effect, right? And if it's affecting the patient enough, we want to make sure that we do our due diligence to bring it forward to the physician through nursing to say, hey, is there an alternative? Or doing the due diligence to notify the physician who ordered it, hey, this is what's happening, right? All right, so let's get to our assessment tools. So we have the confusion assessment method, which is the CAM. It's a short, standardized evidence-based assessment tool to detect delirium. There's 4 quick questions that can assist the clinician in identification process that is sensitive for delirium. And the features are: feature 1, it can be acute onset or a fluctuating course. Feature 2 talks about inattention. Feature 3 goes into disorganized thinking. And feature 4 talks about an altered level of consciousness. And the diagnosis of delirium requires the presence of feature 1 and 2, and then either 3 or 4. I put the link to the test in there so you can have access to that. I think it's a free and open test. And again, deliriumnetwork.org, that's another great website to go visit. Then we go into the MoCA. I think most of you are familiar with the MoCA. It's a quick test designed to be sensitive enough to distinguish between normal aging, mild cognitive impairment, and Alzheimer's disease. It's 30 questions, has several cognitive domains, which are memory, recall, visual spatial abilities, executive functioning, attention, language, performance, and orientation. And I've put the link to the test there. I've already mentioned the patient health questionnaire, PHQ-2. It helps a clinician determine whether to refer a patient for further assessment due to characteristics which are consistent with depression. This standardized depression screening is available as an option for screening patients with depression symptoms. It's a short 2-question screening. The PHQ-2 is 2 questions, and either 2 of those questions, if they're answered a certain way, can open the gate to the rest of the questions, all 9 questions. And if the response shows that the patient presents with characteristics that are consistent with depression, we want to make sure there's a referral to investigate further for this particular patient. Then we have the GDS, the Geriatric Depression Scale, which is widely used with the older adult population to assist with determining if the presence of depression is noted. There's a short 15 question form asking the person how they felt over the past week. And I've put the link to the question there, or to the questionnaire there. And then lastly, we have the mini cog, which is a test for dementia, also has a cognitive component to it. So depending on the results of these screenings and assessments, you may refer patients to other disciplines to assist with structuring the care plan, help with return to independence, etc. If cognitive deficits appear to be worsening as it relates to dementia or delirium, we want to make sure that a referral to OT or speech language pathology is in the mix. If depression appears to be the culprit, working with the agency or the facility to refer to a Master of Social Work, MSW, or back to the physician for treatment would be beneficial. And certainly, any knowledge that you learn from these tests is not to be kept unto yourself, right? You are then to be a messenger to the rest of the care team to the information that you've learned from these tools. And don't always assume that if you document it in your notes that the care team's going to read that. So always be the one that says, I'm going to bring it up. I'm going to mention the results of my test. Usually, if there's a concern with them, if they're all normal, right? We tend not to go too much into normal limits of testing. But when something is triggered in any of these results, you always want to make sure you mention it to the care team. Don't just document it and assume folks are going to read it. You want to be the conduit for communicating and collaborating that information. So here we go into the 3, if you suspect any of these. So after we've done our chart review, we've talked to the family member or the nurses, we've done the assessments, we've done the screenings. If delirium is suspected, you want to thoroughly examine that medication list for any meds that may contribute or worsen the delirium. Again, we're not the decider, but we can be the one that kind of finds it, be the one that say, hey, I think this might be an issue. And it doesn't mean that it is, it just means we're bringing it up to the care team. Establish a connection with the caregiver for effective carryover of strategies and risks, especially if we're still facility bound, if the patient is still in a facility and we know that the patient's carryover of certain things, safety mechanisms to be put in place are not going to be independent on the patient side. They need to be aware, the facility needs to be aware safety might be an issue and this is what we need to do because the patient is not going to remember, not going to be able to follow those safety strategies independently. Determine the level of communication in which the patient is most effective, right? As a speech language pathologist, it's important for our discipline to find the best methods to communicate with the patient. Is it short communication? Is it more conversational style with the patient? And I know there's many patients, especially in delirium and in dementia, where they have difficulty listening to what you're saying and then paying attention to if you're also touching them at the same time. So I tell a lot of our PT friends and our OT friends, sometimes you want to talk, but don't touch. And if you're going to touch, don't talk. So they don't have that conflicting sensory input. They can't pay attention to 2 signals at once. So it might help with reducing any overt physical behaviors they might have. It's better to talk but don't touch, and then if you're going to touch, don't talk at the same time. You want to maximize any orientation strategies, especially delirium. We know they're going to slowly come out of it, so reality orientation is important. Reinforcing where they are, what they're doing, how they're, what's going on, etc. That will help. If communication is affected, we want to know if PT and OT are working with this patient without speech involved, and we think that communication is an issue, certainly bring in speech language pathology for a referral. Same thing for OT if ADLs are suspected. And if the characteristics of delirium continue for a significant amount of time, remember we said it could be days or weeks or longer, connection back to the physician is warranted. If we are still leaning heavy into, we suspect this is delirium because we know there was an infection involved. We know this was a sudden onset because of the characteristics, and it doesn't seem to be resolving. That's when we want to make sure we bring the physician back into the loop. Certainly they're part of the care team in the beginning, but as care is continuing, are we paying attention to that? If depression is expected or suspected, we want to have our referrals out. So ensure a referral to an MSW or other external care provider aimed at further diagnosing or treating the symptoms of depression. We want to make sure that that's in place. We want to look for any signs of suicidal ideation. That's always concerning. You want to always make sure you bring that up if you hear of any of those. Be sure to be alert for any nutritional declines, medical changes, difficulty with following routines or the medication regimen if the patient lives alone or at home. The patient may not be able to maintain that medication regimen if we suspect depression is severe enough that that affects that motivation. Allow the patient to make as many decisions as possible, fully involve them in the process of the rehab, give them control over many aspects of their care when possible. And then educate the patient and the family of the risk factors due to the lack of motivation, participation, and any emotional changes that they may be experiencing. If dementia is suspected, we want to learn the best way to communicate with the patient. Finding out, again, involving the speech therapist for communication side of things. Sometimes if the patient had significant enough dementia where the family is aware of their best ability to function, you want to involve them. Rely heavily on procedural memory and tasks that have a connection to the patient. Involve activities the patient experienced during previous occupations or hobbies. Begin a behavioral analysis. If the patient should become anxious or combative, what was the catalyst for that behavior? What helped reduce it? What helps reduce its frequency? And what helps reduce the time that it happens, right? If something is occurring, if they're having a catastrophic reaction 10 times a day that lasts for 10 minutes, maybe it still happens 10 times a day, but it only happens for 30 seconds because we learn how to redirect. That's a big change. So the frequency may not change, but the intensity or the duration may be affected, all of which may be considered a win for the patient as well as for the caregivers. And as with delirium, if ADLs are affected, consider an OT referral, specifically to help in dining situations. And we certainly know that OT under their wheelhouse can support dementia interventions fully. So we want to make sure OT is involved if needed. And be alert for any pain or fatigue. The patient may not be able to express it and may manifest it as a result of a behavior as opposed to, hey, I'm getting kind of tired, can we take a 5-minute break? They may just decide to physically check out by exiting the room loudly and with arms swinging. So you want to make sure you pay attention to those. So now we're into treatment. During the treatment, how does the cognition change, if at all? If delirium, is it resolving? Is it dementia? Are we able to stack the environment so the patient appears to be able to function a little bit better? Are areas of concern resolving, or are deficits at evaluation still present after several visits? So that's important to pay attention to. Are we seeing the change in the patient's performance that we would expect given our skilled intervention? How are the goals coming along? Checking with the patients early and often to make sure that we have the proper goals in place. Care team best practices, you want to make sure that we involve the care team. Is everybody learning and doing the best with the patient? They may learn something that I would want to know about. So I always ask, anything new, anything good happening with Louise? What unique elements are you getting for her to be able to participate better, right? What are those unique elements? Don't be a gatekeeper. Don't hold that stuff in. Motivational issues. What are you finding helps motivation? What hurts motivation? Times of day, particular activities, what works best? Follow up for concerns for condition management. Knowing how the patient is going to perform when you are not around as a skilled discipline is important. As you remove yourself from the care, how is this condition going to be managed? Are the people in place to be able to maintain the gains you made? Are they present in the care team now? And are you slowly moving things to their care? And then follow up with the daughter regarding any progress and changes. Always involve the family whenever possible. It really goes a long way with them, keeping them involved. And then the expectations for continued progress. We want to make sure that we're revisiting any changes and modifying it as needed. I included here 2 full pages of all the research and the resources that I use to create this. So you'll find 2 pages of that. And now I think I have left a good bit of time, 10 minutes at least, for any questions. And I see that there are a lot of them. So right now I'm going to dip back into Shyla and see if Shyla has any questions for me.
I actually don't have any questions right now. They seem to be all
Comments
administration
and,
questions. Yes.
oh, okay. Well, we can address those as well. Administration questions, the CEUs, in the handout section, there is the ASHA bubble sheet. Fill that out, submit that back to Shyla .hamrick at aegistherapies.com and by next week, so we can submit those. That's for ASHA. For AOTA, there in the handouts is a SurveyMonkey link. I think it's a QR code that will take you there now if you wanted to go and answer the questions now while this is fresh in your mind. I think also Shyla will send out an email to all the OTs and the OTAs to for that survey, so that when you do answer that and answer it to where you pass, you then Shyla will release their certificate for you. And this is approved through Florida and Minnesota and California. Did all three of those get approved for PT, Shyla?
California and Florida did. Minnesota is pending, and the approvals is on the brochure.
Outstanding. So pending means nothing to do on your end, but likely it'll be approved by the time you need it for any licensure issues on the PT side. We submit to those particular states because they tend to cover all the states that take reciprocity. If they say your state says we cover any other state's approval, then you've got California approval, Florida approval, Minnesota approval, and that's how you could submit for your PT or PTA licensure needs.
Okay.
Anything else?
Yes. How do you discern delirium that seems to be not resolving from a possible Wernicke's aphasia?
Wernicke's.
Sorry.
Ooh, good one. Oh, Wernicke's aphasia. Okay, well, the chart might be the answer. If there is a suspected neurological event, or CVA or TIA, you'd want to know, or you would see that in the chart, and you could lean into the concept, is this more Wernicke's aphasia presenting itself, which is very jargon, very disconnected, difficulty understanding, right? That are some of the hallmarks of delirium. So I can see where you would lean in that direction. But I think the chart would tell the tale. If the MRI results are in there, talk about the focal lesions on the brain that might be affected, that's really getting into the weeds. That'll tell you the focal point of the lesion on the brain, which would then tell you, aha, it is Wernicke's, because that's where that's located. Where the lesion is where that's located. But if there's nothing in the chart that tells me there's a neurological event that's happening, I would be leaning more into the delirium. But if it's not resolving, so maybe we have a situation of it's not delirium, but we're having these issues and nobody knows it's neurological. I think that's probably where you're going, right? When do you raise that flag? Well, you raise that flag just by saying what we've been saying. What we suspected was medical onset of a delirium. The patient had an infection, was in the hospital, had some anesthesia, whatever the situation is. And now we're not seeing a resolution. Things are not changing. The patient is still having these, whatever these issues are, you can list them off. What could be causing this? And that's when you turn back to the physician, right? We are the messenger back to the physician for anything we find unusual at this point. So that's when I would turn it back to them. And you can characterize it, say, the patient is presenting with some communication deficits that are aphasia-like. And then you can explain it that way. Say, could there be a neurological component here that is undiagnosed or has not been found? All of these would be proper just to turn back to the physician and say, I'm not the one to do these, make this decision. So I'm giving it to the people that can. So, but knowing when to bring it up, I think is a good thing to remember. That's a good question.
Okay. At what point/level is learning not possible? I've found frequent repetitive tasks with visual cues like tape on the floor to position WC for toilet transfer and note above grab bar helpful, but it can take weeks.
It can take weeks. So when they say level, I think you're thinking dementia level. And for those of you who are familiar with Claudia Allen or the Allen test, Allen levels, new learning, can happen, I think at a 3.8 or higher. So even in middle stages, new learning can still happen with frequent and regular repetition over several weeks. So new learning can still happen with new things. I think you're mentioning where to put your wheelchair, right? That would be a new thing. I'm not used to using a wheelchair. I ambulate on my 2 legs. If I had something happen to my legs where I'm given a wheelchair, somebody would teach me quickly how to navigate and do this, and I would be able to absorb that. That's new learning on an unfamiliar device with a new diagnosis I've never had. And I'm of sound mind, or at least I keep telling myself I am. So I should be able to accommodate all of that new learning coming in. Somebody who has dementia is not going to be able to hear this as a new thing. I've never used a wheelchair like this before. I've never had broken legs or a hip or whatever the situation is. I've never had to ask anybody to get up and go to the bathroom before. I've been able to do it for the last 86 years, all on my own. All of that is new learning. I need to learn now. I have to change the way I do it. And with dementia, it is going to take a very long time to learn one thing new, right? So the wheelchair is one thing new. How to transfer out of the wheelchair to the toilet is the second thing that's new. How to call somebody that I need to transfer from the wheelchair to the toilet is new. So those are 3 new things. You can't learn all 3 of those with that level of dementia, middle stage dementia. So that's important to recognize, that you are not potentially going to put that burden on the patient to be independent. You're going to accept they're always going to need support, they're always going to need supervision, and I'm not going to teach this stuff to the patient. I'm going to teach the caregiver, right? So really good question, really good question. And I hope I answered it. I kind of went off a little bit. I think it came back. Any other questions out there? How are we doing on time? You got a couple minutes, 2 minutes.
Can a traumatic event such as a fall trigger delirium?
Oh, well, it wasn't in the characteristics that I read about. If the fall had a head injury, a head impact, then now we're sort of out of the delirium standpoint and now into a concussive episode. I don't know. I don't think just a fall without injury would be a catalyst. I would think they fell because of something that caused the delirium, an infection, change in blood pressure, a medical event, something's happening in their body, a medication issue, right, can cause balance issues and make them fall. So I would look to what caused the fall as to what might be causing the delirium, as opposed to the delirium itself being a result of a fall. That's my opinion.
Okay. You mentioned development of issues after infection. Is this due to actual infection, the medication to treat, or both?
Repeat that question, Shyla.
Okay. You mentioned development of issues after infection. Is this due to both actual infection, the medication to treat it, or both?
Oh, I see what you're saying. Is it the infection or the meds causing the problem? And it can be either. The infection itself, right? Before an elderly person, when they get a UTI, before they've had any meds, that UTI is making them left of center. They're immediately going to be, and this is potentially, not all elderly have this reaction, but some do, will have that issue with confusion, etc., behaviors. And that's before the medication. And then after the medication comes, it should start resolving, right? That's the hope. And then there are times when the medication that's provided because of an infection or because of surgery, right? Some pain medications, anesthesia sometimes we know can cause issues with this. If the patient was in a medically induced coma for a period of time, coming out of that is a type of delirium, and that's medication induced in those cases, in many cases. So I think it can be both in either direction.
Okay. Have you experienced issues with insurance covering treatment for SLPs treating a patient with no dementia DX but delirium only?
I haven't seen it recently, but here's what I would do. I would describe that the patient does not appear to have any past history of dementia or dementia illness or dementia diagnosis. However, the patient is presenting with this laundry list of issues. And then I go into what would happen if I don't treat the patient. Should the patient not receive SLP services at this time, the patient is at risk for decline in communication, safety issues because of the communication problems, poor nutritional intake, confusion during meals, which could potentially cause choking, right? If you've got inattention during mealtime, you're not chewing adequately, there could be some dysphagia related. So I throw a dart and hit it head on. Yeah, I get it. There may not be dementia, and here's delirium, and it may resolve quickly. But if while they're in here, my skill is to make sure nothing else goes wrong. I may not be in here for very long. Hopefully everything's going to resolve. But while we're here, I've got some skill that I can lay down, that I can do to help avoid the patient running off into the, off the side of the road while we're here. So I talk about what happens should I not intervene, what could go wrong. That's the medical necessity. I would shoulder into the medical necessity, why I'm here.
Do we have time for one more, Shannon?
Oh, sure. Why don't we do one more and then we'll wrap it up.
Any good resources on determining frequency and duration of treatment?
Oh, goodness. That's not one that we can end on. That could talk for 4 days on frequency and duration. Boy, that's not an easy one to end on. Okay, I know it's one that therapists always want to know. What's the easy answer? How often should I see somebody, for how long, and how often per week, for how many weeks, and then how long in each session should I treat a patient? We want to be able to put that into a machine that's not our own brain and have it come out, right? And then we worry that are they giving me something I don't think is right? So algorithms aside, yeah, I look at what is it's a simple comparison. Where were we? Where was the patient before? What were they like before? Where are we now? And where do we need to get to? So here we are now, and with some causality, right? What caused where we are now, which helps me know if we can get where we could get to. And then I look where we are now to where we need to go. What are the steps involved to move the needle in the direction of that goal? And that goal may not be full independence or back to prior level of function. It's to the next level of care. When the patient's in the hospital, their goal is not to be, the goal is to move them, to step them down in the environment and then ultimately discharge them home to continue to receive care and continue to resolve. Same thing in a skilled nursing facility, same thing in home health. You want to get them to where they no longer need your services in your environment. So what are my steps to get them to where they're going to be able to go home? And then in those steps, what's the breakdown? What's the breakdown of those individual elements that I need to do to move the needle for independence, whether it's mobility, whether it's ADLs, whether it's swallowing, communication, whether it's learning what type of cues they're going to need at the home. Do they need to be able to operate their phone, right? If I'm a speech therapist, what's that? Money management, if that's an issue, that higher level things. So I know what those steps are, and then I say, okay, how many steps do I need to get them from from the current status to their end goal? And does every single one of those steps need me to be in front of the patient to achieve that? And I say that in knowing that I'm going to have to involve other people, right? I need to turn over some things to the daughter, to the family member, to activities. I'm going to use what's around me, what facility elements, if I'm in the SNF, what facility elements reinforce or facilitate what I'm doing with the patient and help keep it going when I'm not there. So does every step, so that's your number of times per week, how many in those steps does my face need to be in front of the patient to achieve that step? Sometimes yes, the answer is yes. And sometimes like no. There's plenty of things and plenty of other people I can involve to move this along, and I'm confident that can happen so that I don't have to have the frequency be all 100% me all the time. And then I map that out. Do I hit it 100% of the time? Sometimes do I need another extra 2 visits? Do I need an extra week sometimes? Yes. Sometimes I'm like, I'm so great, I can chop off 2 weeks. You're doing so fantastic. We don't need any more of this. And then we can discharge early. So knowing the care team's all in agreement, et cetera. So it can be a moving target, but that's sort of how I go about it in my head, how I facilitate where were we, where are we going, what are the steps needed, and do I need to be present to move the needle for each one of those steps to get to the goal? That's a long answer, but hopefully sufficient. That was a 3-minute answer at the end of this. I so thank all of you for joining me here this evening. I appreciate everybody's time and attention. Here's my email. Feel free to reach out. You can email me with any questions. If you need any help with the ASHA sheets or with the survey, please reach out to Shyla. Her email is in the handout. It's Shyla, SHYLA .Hamrick, HAMRICK, at aegistherapies.com. You see the rest of the link there in my email. She's my great moderator here, and she'll help you with any of the nuts and bolts of the CEU elements that are there. I appreciate everybody's time. Thank you, and have a great rest of your day.
Thanks, guys.
Thank you.